What if your next prescription for pain relief was a virtual reality headset instead of a pill? Our guest today is working to make that scenario a reality. Hi, welcome to Beyond the Paper Gown. I'm your host, Dr. Mitzi Krockover. Let me start by asking you to picture this. You go to your doctor for chronic pain. She reaches for her prescription pad, but instead of writing for a pill, she literally prescribes a virtual reality experience. It might sound surprising, but that's exactly the kind of future my guest today is working on. Dr. Mary Catherine George is a health psychologist, clinical research program director in the Neurology Department at Mount Sinai School of Medicine, and the founder of Comfort Wave VR, and she's developing VR technology to help women manage pain after breast cancer surgery. Her path here has been anything but traditional. She's been an opera singer, worked in HIV research during the height of the pandemic, and has even done stand-up comedy. She brings all of that experience, plus a deep curiosity about why we hurt and how we can hurt less, into her work. Today, we'll talk about why women often underreport pain, what role behavioral medicine can play, and how immersive technology could be a new tool for relief without a single opioid or other pain medication. We'll also get into the realities of bringing an idea from the lab to the patient. I think you're going to come away with a new perspective on pain and maybe even on healthcare itself. And just a reminder, this podcast is for informational and educational purposes only and is not a substitute for medical advice. Today, I'm excited to introduce our guest, Dr. Mary Catherine George, who is a health psychologist, a clinical trial specialist, and clinical research program director in the Neurology Department at Mount Sinai School of Medicine. And she is also an entrepreneur. She's very passionate about improving care for patients suffering from chronic pain and complex conditions. And I'm looking very forward to talking with her about this. So welcome, and she's given me permission to call her MC. So
yes,
welcome,
definitely.
MC.
I'm from the Deep South, and double names are common. So it's easier for Northerners to say MC than the Southerners down in the South who love to elongate things, you know. So definitely.
Being from Texas, I understand.
Yes.
So, well, terrific. Well, thank you for being here. And you and I met, and I had the pleasure of meeting you because you actually won the Women's Health Tech Pitch Challenge Award from HitLab.
Yes.
And so congratulations.
Thank you.
And I'm delighted that you're able to be with us today.
Me too.
So just to get started, because again, we're going to talk a little bit about a number of things, but what's really fascinating to me is that here you are in the research program and a health psychologist, but you actually started out as an opera singer. So talk a little bit about how that pivot happened.
Well, I came to New York City in the late 80s, early 90s, and was singing with City Opera, who lost a grant, I was singing with their educational program. Suddenly no funding, and my brother was working at St. Vincent's Hospital, and he said, well, why don't you work with the research team here? And I'm like, I don't know anything about medicine or science. He said, well, just talk to them. So I did. I talked to the doctor that was head of the HIV/AIDS Center, and it was in the midst of the huge HIV/AIDS crisis. And he said, well, we're losing the person who helps us with research. Why don't you speak to her? And I can never forget Garance Franchi-Ruta. I think she eventually went to Harvard and is now a doctor somewhere. But she kind of showed me this drawer of paper, and I thought, well, there's not a lot of blood or anything, so maybe I can learn this.
I should also say that you are a stand-up comedian as well.
Yeah, I do a lot of improvisational and stand-up comedy. Because
I
truthfully,
love that.
you have to come at life with a yes and. That's I promote yes and all the time, which probably gets me into trouble. But I think, the curiosity was high, and also too the whole dynamic around HIV and AIDS at that time was in such a critical place that there were so many people from so many diverse backgrounds. It gave me permission to allow me to enter this field, which I thought was magnificent. So I really, boots on the ground, rolled up my sleeves, and we were overseeing something like 60 studies at St. Vincent's Hospital, went through that whole apparent, dynamic of the changes that we got medicines that made people live longer. And so, now it's a chronic illness. And then I transitioned to working at Mount Sinai in 2000 and became even more fascinated by chronic pain. It's like someone's dangling a behavior of patients, and it was so fascinating to see people who were clinically the same but would report this pain so different by everyone. It was so it drove me my curiosity. So I started writing protocols with the neurologist there, and then finally one neurologist said to me, he says, well, if you want to be part of this team, you have to go back to school. I'm like, oh dear. So I rolled up my sleeves and went back to school and got a PhD in health psychology.
Wow. And what is health psychology?
Well, health psychology is really looking at us as individuals holistically. Like, what is it that helps you become a healthier individual no matter what your circumstances are? Like, do you have comorbidities? Do you have genetic issues in your family? What are your thoughts and feelings about the condition that you are in, both physically, mentally, and sometimes spiritually if it's relevant to that patient? So it's really a field that's new, and it's not really about treating someone clinically, but it's really about understanding from a bigger picture, how can we do research, how can we do programs, how can we help patients understand their health, because health literacy is just very, very low.
So before we talk about the technology or the intervention, as you were speaking and you had talked about being a health psychologist and looking at pain and the fact that women may underreport their pain, I also wonder about what's the effect of pain on healing? What's the effect of pain on psychological stress? All of that. Is that part of what you're thinking about as well?
Of course, we know that chronic pain contributes so much to how a person goes about their activities of daily living. And if you are in chronic pain, I can't tell you how many patients I've spoken to where their activities of daily living have just completely reduced. Some people are not even walking out to the mailbox, or they're not doing the kinds of things like family activities, or they're just not as engaged because they have this pain. And sometimes it's a fear, if I overdo, that I'm going to have more and more pain, or if I do what I've always done, and maybe my pain will be the same. So it truly is a real difficulty, and people have to really work with themselves. And one of the biggest challenges is helping a person who has chronic pain do some behavioral interventions. When I talk about this with, most clinicians, very few of them, because I think it's all about access, very few of them say, please take a gentle yoga class. How about mindfulness? How about a CBT program? How about self-hypnosis? I want to tell you, so few clinicians will encourage patients to look into behavioral types of treatments. And so what would happen at the hospital is the physicians, the neurologists that I work with said, oh, why don't you talk to Mary Catherine about some behavioral techniques that you could look into? And there's so many, but it's a total different approach than taking a pill. If you're going to do behavioral medicine, it's really about action and setting time aside. And sometimes that is very difficult for people with chronic pain.
Absolutely. And, to your point, we as physicians were not trained in that behavioral medicine, but we were trained in, again, I kind of think of this as kind of the male model, if you will. Sorry, gross general stereotype, but we want to fix it, right? We want to fix it fast. And we don't know about the behavioral medicine. Plus, doing that also takes more time, which is at a premium for physicians.
Yes.
So not to defend things, but to maybe put it in perspective.
Yes, I totally agree.
And I think, as you're pointing out, now there's more and more literature that's suggesting, or not even suggesting, but showing that some of these modalities that you mentioned are actually effective. And how do we integrate that into our into practice? So talk a little bit, because I think folks will be very interested in what are some of the modalities that have been shown to help that you mentioned, and which ones seem to be the most effective?
Well, I think that mindfulness is something that's huge. John Kabat-Zinn created his mindfulness practice for chronic pain. And I think it's an 8 to 12 week course where trained individuals, and what they do is they take you through a process of showing you many, many mindfulness practices. Meditation, breathing, walking, just a ton of practices with you. And, teaching a person to help them take that and integrate it into their lifestyle. And we did do a study several years ago that looked at a mindfulness type practice versus just education, and clearly teaching people a mindfulness practice in this dynamic was so successful. But again, one of the things that I'm so very aware of for patients is it's not easy to set up a small bit of time for you to breathe, or to walk, or to engage in some meditation, or those types of practices. You really need to give the patient a tool, something tangible, something physical, something that will guide them potentially. And that's why I think there's an explosion of mindfulness apps. These have all been extremely popular because they do help, and they're giving you that sort of like touch point of something where you don't have to do the heavy lifting. But this is only accessible to people who can really pay for it. It's not covered by your insurance.
Though some employers have been seeing the benefit of that. So, that is one way. But so then, enter Comfort Wave VR. How did you come to that solution?
Well, I've always been fascinated by the concept of virtual reality, of this idea that you can somehow enter into something that feels outside of you, but you're still present in it. And I love this idea when it comes to behavioral medicine, because we all walk around with our perception of who we are. And I'm fascinated by the thought of can we give someone in a virtual reality dynamic a different perception that takes them beyond what their perception currently is. So, and that really is a very, I think, to me, the process for self-hypnosis is a natural, because we're actually asking a person, when we're teaching them self-hypnosis, to think of a place in their imagination that is comforting that is sort of taking them many patients either reflect back like, I want to sit in my grandmother's kitchen. I want to be on the balcony of my father's beach house. So you're taking that person back to some kind of an experience that gave them a great deal of comfort and relief and just has this very nurturing feeling. So I was like, I've just had this desire. And when this company that created something for back pain came on the market and I saw it, I was like, okay, now's the time. I want to make this happen. So I just went after it because we had done a self-hypnosis study earlier in a HIV chronic pain population and saw great benefit. But it's very hard to take things from research into the market. I'm learning that more and more every day.
So is there something different, for example, in addressing pain from back pain versus potentially HIV versus post-mastectomy pain?
So pain is a real challenge because really we don't have a good way of measuring it right now. Every time we ask a patient about their pain, they're telling you their experience, and it changes from day to day. It can have so many layers of what it is. It can be dull, aching, deep, narrow. I had one woman tell me, I can't describe it. It feels like some kind of water running on my leg that burns. Mm-hmm. And so one of the things that's really clear, if it's neuropathic pain, where it's really those nerve fibers that are misfiring or miscommunicating to the brain, those are really unusual experiences pain-wise. And then musculoskeletal pain, those are functional, sort of like your joints. And most of the time, people have layers of this. Right. But it's difficult to differentiate. And so you really have to go with what is this patient telling you about their average pain. And getting someone to help them understand, to give you a score, is not easy. But we really work with people to help us understand their pain. And in the future, what I'm hoping is that we're really going to find a biomarker. And this is going to help us tremendously. But we're not there yet.
Explain what you mean by a biomarker for pain.
Well, there is some evidence that there is a way that our brain and our body communicates to itself that we might be able to measure with blood work or in some type of a concrete way to determine that, when we see this in someone's blood work or this in someone's RNA or DNA or something like that, this gives us a sense of their level of pain. But I think that this is still very much in the development stage. And I think, we do have some evidence that it's very malleable and that we can give people placebos and nocebos and it helps. And it's not anything beneficial other than what we're thinking. So it's tremendously complex. But I think as we have more AI and large computational data, that we can start to begin to look at where are we in similarities and differences and patterns. And this is going to be a game changer when we get there. We're not there yet, but it will definitely help us.
And I guess as you're speaking, I can see it may be that what is painful to one person is not painful to another. It's like it's a reminder that it's cancer, or it's a reminder that something is, that the level of anxiety about that really amplifies the effect of that pain.
Definitely.
Is that a fair statement?
Yeah, it really is. And I think you also have to think of, too, the environment someone's in. I'll never forget when I had a patient's son ask me to speak with his mother. And she'd had terrible pain, and it was a real struggle, many back surgeries. And when I spoke to her, I realized the secondary gain of her having a pain condition was much stronger than her finding pain relief. Because of what would happen with her family, she got a lot more attention. She got more visits from her son. And so I thought, this is a person who, she probably has some tolerable pain, but she's never really going to give up on her pain because there's too much goodness that she's getting by still having it. So there's always going to be some things that are present that we don't understand kind of unconsciously. And I think when we as psychologists are assessing someone, you have to understand what's going on in their environment. You have to understand what's going on in their family dynamic. Sometimes you have to understand, how patients feel about their pain or their pain from family. Maybe they had a patient, a person in their family who had diabetes, or they had some role model who just really rose up and kept going despite all their pain, and this is the model that they have. So it really is a fascinating area of field of discovery for me. And I just am truly excited to have some data from this research that I'm getting ready to launch into.
The technology that you created was focused on, or is focused on, post-mastectomy pain syndrome. So again, you said that you've, came from HIV and then chronic pain, and now this is a very specialized area. How did you get there, and why did you think it was important to address?
Well, I was part of a very early team that did work on what's called the Qutenza patch. Very fascinating treatment that's available on the market now for what's called diabetic neuropathy. And this is a patch that you put on the skin for 30 minutes and then take it off. It's made from a high concentration of capsaicin, which is what's found in chili peppers. Mm-hmm. So it's very novel. And they were saying they were going after post-surgical pain. And I was like, really? And so there was a grant that was available. So I did a deep dive in the literature, and I thought, so what's relevant to cancer and women that's post-surgical pain? And I uncovered post-mastectomy pain syndrome that just blew my mind away, that this is the highest pain condition in cancer, period. And I thought, you're kidding me. I'd really never heard of this before. And apparently what's difficult about it is I think many women who are survivors of cancer, who may have this pain syndrome, don't feel like they need to complain about it. Or they may not feel they can come forward and say, where I have surgery, it's still burning, it's stinging, it's shooting pain. It's very unique pain. So I anticipate that as I prepare to go after enrolling participants in the study that have this condition, we're going to discover a lot more about the types of pain that these individuals report. I think we're going to uncover maybe a little more about the incidence of it in the population, because there's not a lot that we do know. We do know it occurs. We do know that patients tend to not report pain. Women are really bad about reporting pain. Yeah. We're supposed to be resilient and, keep going despite everything. So I anticipate that once we open this door, that we're going to get a lot of information, which I'm excited about, because I am a qualitative researcher, which mm-hmm. means I want to hear your story. I want to hear your description of what you experience. And we've included a lot of that in our research components so that we are getting the stories from the patients, both before they use the ComfortWave VR and then after, and then even further after, because I truly want to understand how can I make something available to patients that really can be a tool that will help them reduce their pain experience.
What have you created thus far, and what's the approach?
So we've created the software with the engineers and have put it into 9 headsets, and our first testing was all on ourselves. So me and the study team and my co-investigators, we all have done the testing and refined it, because one of the things you want to do when you're working with virtual reality is not virtual reality, it does it through a visual tracking of your eye movement. So you want to make sure that you're not going to make someone dizzy or nauseous, because they're going to feel a sense of even though we're taking them out of their body into this other perception, we don't want to make them feel like they're losing their balance or they're feeling unstable or anything like that. So we really focused on creating something that replicates what someone might have in their imagination as an experience. And, we're using sort of a narrative that was the most common that many patients say they want, from about, I think, 200 to 400 narratives that we had available to us from my co-investigators. So we really are excited about this first iteration, but do I feel like it's going to be the winning iteration? I doubt it.
Sure. And so you talked about self-hypnosis. So is it basically, instead of having to do the hard work of visualizing that, you do it for them?
Yes. So what we're doing is we're transporting them to a location with a narrative and sound and visuals that somewhat replicates what you might do in your imagination. But it's very concrete, it's very stable. So often when you're taught self-hypnosis by a clinician or a hypnotherapist that's licensed to do so, there's so much variability from patient to patient, clinician to clinician, in the tone of voice, in the inflections, in the spacing of what you're, saying to someone. And that really makes difference. And so we're hoping and have a hypothesis that if we give someone a very concrete experience in a virtual dynamic that makes them feel they're outside of the pain that they experience, that this would over time remodel that thinking in their perception of their pain. But this is still just a hypothesis. And
right.
We're hoping...
We're very early on.
Yeah, we're very early. So we're hoping that this might do that. And we're very excited to see... because so far with all of us testing it, but we're very biased, because we built it, I am very happy with the results. I feel like I used it on myself for a hysterectomy that I had in October. I didn't have to use any opioids after the hysterectomy. I only had to use it once in the hospital. And I have a hip replacement now that I'm having at the end of this month. I'm going to use it for that too. And just do it the whole week prior to the hip replacement and see what happens. So, of course, I'm very biased. And maybe I have what they call more hypnotizability. But hey, anything that will reduce pain, I'm in there. Because sure. I know from firsthand, I know what pain is, without a doubt.
Yes. And so, kind of a random question, but I can't help but ask it. Mm-hmm. As an opera singer, how important is music to pain relief?
Oh, my goodness. So, before I was able to develop this, I really encouraged patients to explore virtual reality and some of the dynamics that are out there. Because really, music transcends us. It really, if there's something that you in your spirit, your mind, your thoughts connect with, music is a powerful, powerful tool. And I think, we all as human beings, and I know how much music has empowered me as a person. And I believe that it is tremendous, and that we're just now understanding maybe what music can offer. And I open my door to potentially layering in some music that might be influenceable. There's some other things that I'm hoping to layer into the process. And if you can do a combination of visual and hearing to give a person an experience, you can really change them and give them something, because that's really what I want. We want people to still engage in their activities of daily living, enjoying life, and not allow their chronic pain condition limit them from experiencing their life fully. I think that's what drives me. I want people to live a life that's full despite whatever their chronic pain condition is. And, because I've just seen so many people who struggle, not only from the side effects of their pain medicines, they're making them overly sedated or making them feel sluggish, or they don't feel quite themselves, but they feel like this is the only thing that'll help them get pain relief. My hopes is that if I can add this to their pain regimen and it gives them more functional access to their life, I'm thrilled. That's what I want.
Sure. And you talked earlier about the accessibility of some of the apps that address this. And so what you're talking about is a VR program that I would assume would require something like Vision Pro or Oculus or something like that. So how are you thinking about making your technology more accessible?
I went to the FDA right away and I said, hey guys, I want to be able to bring this in as a combination device for FDA approval, because I ultimately want to have a pain doc or a neurologist or a primary care provider be able to prescribe you this treatment and have it shipped to your home. Because if you have the headset, you don't need Wi-Fi. It's already preloaded. You can use it. I anticipate that maybe as we learn more, we can get it so that it can just be something where people can add more scenarios as a download into the device. But, I just want it to be so accessible, because right now, behavioral methodologies are not. They're not accessible. Patients have to figure out, do my insurance cover it? Where can I go find it? Is there a hypnotherapist? Where's the cognitive behavioral treatment? I mean, there's just not the easy access that I would love to have for patients. And that's what I ultimately would love to see, is that this can be prescribed, it can go to your home, and then you have it, and then you're checking in with your pain doc with a telehealth or a telemedicine way, or that you have some therapist that's working with you. How's it going? And I just think that this would be a real answer to patients if we can make it accessible.
Sure. So let's shift a little bit, because I think it's fascinating. We don't usually get to talk to someone who is really at the beginning of their entrepreneurial journey. So take us through briefly what it's going to take to get that not only FDA approval, but get it on the market. Just some of the steps.
Yeah, I'm very fortunate in that I'm a regulatory maven, and I know that where to go look. And so me and the FDA, I know a lot about the process. And I knew that if I could get something that's called a breakthrough device indication from the FDA, that sets me up for having to do only one large pivotal study to get myself into the market. It also gives me the opportunity that once I show that it is beneficial, to get to the head of the line to get insurance coverage for it. So when I went through the process of what's called a Q submission, where you're querying the FDA to say, what would you want to see as evidence? Well, they were very helpful, but it was also very challenging. They want to really see some biological measures. They want to see heart rate. They want to see brain waves. They want to see MRIs if I've got it. So those all cost money. So I'm doing everything I can at our institution to find collaborators who measure that and get them involved. And I'm looking right now to see how I can get brain wave measured. I'm looking at how I can get heart rate measured, because those would be two very powerful measures, if I can include them in the study, to give to the FDA for a rationale to get my breakthrough device indication. So that's what I'm going after, because I know, as someone who's been in research a long time, if you're having to do 2 and 3 studies that you need, hundreds of patients to validate what you're doing versus a placebo or something that doesn't do what you're wanting to do, it can cost millions. And that's difficult in this kind of dynamic that we're running into. You're looking for venture capitalists who believe in you. You're looking for federal funding, you're looking for grants. And so how many rejections have I had? A long, long list. But I think every researcher has a long list of rejection. But this seems longer because I think I have 2 things against me. People hear hypnosis and they're like, oh, this sounds like some woo-woo stuff.
Right.
And then they hear VR and they're like, where's the market in that? So I totally have an uphill climb. But one of the things that I truly know about myself, and maybe that's because I'm a performer, I'm extremely tenacious. And I'm very, very familiar with rejection. And it doesn't dampen my enthusiasm whatsoever.
And you alluded to, some of the dynamics, as I know as an investor looking at companies like yourself, it's always preferable to get what we call non-dilutive funding, grants that don't take any equity. And a lot of companies like yours use those grants to get the research done, to prove the premise and to, move on. In this environment right now that we're in, especially because you've chosen a women's health issue, and that has been also an added challenge in terms of grants.
Maybe this is because I'm from the arts originally. I tend to see things with, the door's closed, but gosh, I bet there's a window somewhere that we can find here. Or maybe there's a trap door, and because that's what I am. I'm an improvisational person, and I'll never forget when we would do improv. We toured we toured all the time. And when things weren't working, we would just burn it down. We would sing, "Let's Burn It Down," or we would kill ourselves, or we would just do something so that we find an ending. And I have to tell you, the one thing I can recommend to everyone, if you want to deal with life in general, go take an improv class. You will become much better at saying, okay, where's the trap door? The doors are closed, the window's locked. I know there's a trap door around here somewhere. So I think that's really where we're at right now. We don't know what's happening. Things haven't settled. But eventually, we all know we want health care for women and for our population in general to be better. So if we keep the end in mind, that's really what we want. And how can we argue with that end? Making people's health and their lives better. And reducing healthcare costs.
I was just thinking the same thing. And the use of, opioids or any other kind of pain medications, which have their own challenges. Mm-hmm. That was great advice. I hope all the entrepreneurs out there were listening as well. So where are you now with Comfort Wave VR?
Well, we're getting ready to begin enrolling possibly in June because we had some delays with the engineering company. So we're almost there, and it gave me the opportunity to kind of refine some of the things around the protocol that really I think were being asked of me by people who had venture funding and other physicians who said, how are you going to measure how long this kind of a treatment lasts? And I think that's a question I had thought about, but I hadn't really thought at a length of how to measure that. So we were able to go back and restructure the protocol a little bit to get more information about how it will last. If you give this person a treatment for 3 weeks, will it last for 4 weeks? Will it last for 9 months? What will person's pain perception be at a later date if they're not accessing the tool? So that's a question that I think we will address by doing this study and get more data and information. So I'm very excited about that. And also, too, it's giving me an opportunity to really find those partners who can do the brain wave measures, who can help me with the heart rate variabilities. I don't know what I would have done if I did not participate in what's called the Mount Sinai Innovation Partners. I didn't have any idea what the entrepreneurial road was or making a pitch. I'm going to tell you something. I learned so much to do a pitch for your topic in 5 minutes. That is difficult. It really pushed me to the limit. But you know what? If you push yourself, guess what? You find yourself making it happen.
Not only did you do it, you actually won.
I know. So. That was shocking to me. I mean, but I kind of like it. The only thing is that as a performer, I get a little passionate and a little choked up sometimes at the end. Wow. But I'm getting better at that.
I don't know I think that's a feature, not a flaw.
Oh, okay. Well, I don't know.
Oh, well, Dr. Mary Catherine George, it's been delightful getting to talk with you and learning more about what you're doing. What did I not ask you that you wanted to make sure our listeners heard? Well,
I think that as far as right now, if people are out there suffering with pain, I really would love it if they would investigate some of the things that are the easy tools online that are free. There are so many virtual reality tools that you can investigate that are available. And that's what I would tell patients to explore. Like there's this one free, I think there's a list, I can't remember them off the top of my head, but there's so many phenomenal things that you can experience. Now, granted, I don't think it's going to give you what I'm hoping Comfort Wave will do, but it might start to offer you a different way of looking at your pain. And it sounds crazy, but to get curious about your pain, to be a friend to your pain and figure out, what is it wanting to tell you? I know that sounds, again, in the woo-woo world, but that to me, it is something that invites in an opportunity for more pain relief, because you're really offering yourself, because this pain's part of you in some way. You're offering yourself a way to befriend it, to get to know it better, to be able to describe it and understand the fluctuations of your pain, and it's not static. That's one of the things that I learned so much, is that people have sort of a cycle of what their pain experience is. And I think that's what fascinates me, is to hear the pain narratives of all of these patients and how totally different they are from person to person, and how challenging it is to capture what that experience is. It's like, how do you tell your doctor that it feels like a fork is stabbing in the middle of your foot and then your whole leg is encased in cement? What is that? I can't even imagine. But that's what people are describing. So I think if you have chronic pain, is to not give up and to keep looking for more answers to help you.
That's great advice. Well, again, Dr. Mary Catherine George, thank you so much for joining me today.
Thank you, Mitzi. This has been a wonderful opportunity for me, too. I can't tell you how thankful I am to get the news out there about what I'm trying to make happen with Comfort Wave.
And I look forward to down the road. Maybe you'll come back when you get your FDA approval.
Let me tell you something. I'm going to be shouting from the rooftops. Especially if I get the breakthrough device indication. Oh, I'm just going to make that like everybody's going to know about it.
Thank you.
Thank you.
Thank you again to Dr. Mary Catherine George, Clinical Research Program Director in the Neurology Department at Mount Sinai School of Medicine and co-founder of Comfort Wave VR. I really enjoyed this conversation because it wasn't just about technology. It was also about the journey. Dr. George's path has taken her from the opera stage to HIV research during a critical time in public health to developing a new tool for helping women manage post-mastectomy pain. Along the way, we talked about why women sometimes don't speak up about their pain, how behavioral medicine can make a real difference, and how changing the way we think about pain can sometimes change how we feel it. I find her approach both practical and hopeful, finding ways to bring something as complex as virtual reality into everyday care so it's accessible to the people who need it. It's also a reminder that innovation doesn't always happen in a straight line. Sometimes it's about following your curiosity, learning as you go, and finding an open window when doors appear closed. For an entrepreneur, that's especially important. Dr. George's story really underlines the perseverance and passion that's needed on top of expertise to bring a solution to patients. Thanks for joining me for this episode of Beyond the Paper Gown. Please don't forget to rate us and subscribe here on your podcast platform. And I also invite you to visit beyondthepapergown.com to subscribe to our newsletter and to find more information, articles, and news on women's health. And as always, take good care. Our episode was produced by Patrick Shambiati and me, and our associate producer is Kyla McMillian.